A hearty good afternoon and welcome to our session on anemia in pregnancy. We're glad to have Dr. Chandana Galidevara among us today to help us understand the topic. Inadequacy of healthy red blood cells to carry oxygen to tissues in the body is known as anemia. And anemia during pregnancy should be treated seriously as it leads to low birth weight, premature birth, and even maternal mortality. It's important to understand this topic first of all to be able to tackle it. So feel free to ask the doctor any questions or clear doubts with the doctor. Doctor, you have the stage.
Yes, thank you so much for the introduction. And I'm going to give you a gist about anemia and pregnancy, the importance of having correct hemoglobin levels in pregnancy, and what effects it can have on the maternal side and on the baby, unborn baby side, and how to treat it. So, coming to anemia and pregnancy, anemia is such a common problem. It is global problem basically, and the incidence, the worldwide incidence of anemia is almost 40%. But when it comes to India, the studies are so vast that they say the prevalence ranges from around 50% to almost 70%. So some areas have anemia and pregnancy as high as 70%. So that is the magnitude of the problem we are facing with. And to define what is anemia, anemia means having low red blood cells in the blood and decreased hemoglobin. And how do we, what is the cutoff we use for hemoglobin levels? As you all know, the normal hemoglobin level is between 12 to 16. And in pregnancy, we define the cutoff as less than 11. So 11 gram per deciliter is considered as anemia in pregnancy. That's what the WHO definition is. Usually it so happens that pregnancy is a hyperdynamic state and there's a lot of fluid retention in pregnancy. So automatically there is some amount of dilution happening in the blood, because of which the hemoglobin levels falls physiologically. So because of the increase in the volume expansion of the plasma and the water retention, we do expect a fall in the hemoglobin normally, but the fall should not go lesser than 11 gram per deciliter. So it can range from mild, moderate, and severe. So the severe the anemia, more the problems. Now that's about the definition and the cutoff values. Now coming to why it is so common in pregnancy. The reason is in pregnancy, basically we have a compromised nutrition. In India, we have a low reserve to start with. Basically, our reserves of hemoglobin are not optimum when women get pregnant. And following that, what happens is in the first trimester, especially, the food intake decreases because of the nausea, vomiting. So most of the anemia we see in our clinics is basically nutritional anemia, which is due to less iron in the food. So food dietary advice is a very, very important part and very integral part of treating anemia. But dietary intake can only work if it is mild anemia. So once it becomes moderate, then you need to resort to tablets, injections, etc., which I'll be discussing further on. So coming to the nutrition, what are the signs and symptoms of anemia? So how do somebody present if they have anemia? Most of the time we do a blood test in pregnancy. When somebody becomes pregnant, we give them blood tests and we detect it. But sometimes if it is moderate or severe, they do present with symptoms like breathlessness, easy fatigability. These are very non-specific symptoms, but of course they are the symptoms. Breathlessness, which progresses, might indicate that the anemia is worsening. And also easy fatigability. Sometimes there is another symptom called as pica. That means women might develop some kind of liking for weird tastes, like they might like to have some charcoal or salt, so or even mud. So that's called pica, which is also a symptom of anemia. So these are the common symptoms. But when you see if somebody has a severe anemia, the symptoms are much more severe. There can be breathlessness, there can be swelling of feet, and in worst cases there can be even heart failure because the heart is not able to pump blood. The blood volume is high, but the iron oxygen carrying capacity is so low that the heart starts failing. So that happens when the hemoglobin levels fall very less. So these are the symptoms and signs. Basically, we look when you come, we examine the patient and we look for the pallor. So somebody's tongue and somebody's conjunctiva, that is the lower area in the eye. That redness indicates how pale somebody is. And of course, we look for the respiratory rate and other signs. And the most important thing is the lab measurement of doing a complete blood picture. We do a complete blood picture where we get to know the hemoglobin levels, and also there are some important other lab parameters which we call as indices. So if you have seen a complete blood picture report, you can see that there are a lot of things. First is the hemoglobin, then there is the white cell count, total counts, then there is a differential count. So differential count all deals with the white blood cells. So coming to the red blood cells, you can see that there is a packed cell volume. So packed cell volume is nothing but how much of RBCs are compacting together. So the more the packed cell volume, the better it is. The lesser the packed cell volume, it means there is deficiency of the red blood cells. And there are other indices like mean corpuscular volume. That is, what is the volume of each RBC, and mean corpuscular hemoglobin. So each of the RBCs, how much of hemoglobin is it carrying, and mean corpuscular hemoglobin concentration, MCHC. So these are the blood indices which are commonly reflected in your complete blood picture. They can give you an idea about the severity of your anemia. So once we confirm with the lab, there's another test called as peripheral smear. So peripheral smear is what we see. We take a drop of blood and then we examine it under the microscope. We see how the blood picture is. And most of the time, the nutritional anemia, which happens because of iron deficiency, which is the commonest, presents with microcytic RBCs. So these RBCs are very small and they are round or they can be elongated. So there are varying shapes, but the cell volume overall is smaller. So that is the peripheral smear picture, which we call as microcytic. So microcytic in the sense smaller cells. So smaller red blood cells than we expect in a normal person. So these are the lab parameters, how to detect anemia. Like I said, anemia, the cause most commonly is nutritional because of iron deficiency, but there are some other causes as well, like vitamin B12 deficiency. So, vitamin B12 deficiency is becoming very common these days. Usually, vitamin B12 is a component which is deficient in the vegetarians because they say B12 is present in the non-veg sources. Don't know, is it because of the absorption factor that even non-vegetarians can also have a B12 deficiency, like somebody has malabsorption or the B12 levels are not adequate, they can also have a B12 deficiency, which can present as anemia. But the blood picture in a B12 deficiency is slightly different because when we look at the peripheral smear, the B12 deficient anemia person has larger cells. They have larger cells, but they produce very ineffective hemoglobin. So again, this hemoglobin is not very ideal to carry the oxygen to all the cells. So you have a macrocytic picture if it is a B12 deficiency, and you have a microcytic picture if it is an iron deficiency. And there is another vitamin called as folic acid or folate. So folate deficiency can also present with anemia. And generally in all pregnant women, we do start supplementing folate right from pre-pregnancy when somebody is planning, or the moment we find out that somebody is pregnant and we confirm with the scan, we start them on folic acid. So folate deficiency can also lead to anemia. So these are the commonest causes. Apart from this, there are other causes as well. If somebody is losing blood, somebody is having repeated bleeding from the vaginum or from any other natural orifice, can be something like repeated bleeding gums or recurrent bleeding from the food pipe or recurrent peptic ulcer bleed. That can also lead to some amount of blood loss and in turn anemia. So that's about the gist of the causes. Now, coming to the correction. So, correction, when we say about correction, the nutritional component plays a very, very important role. And then you have the medicines, which are either in the form of tablets, or if it is not getting corrected, not responding to oral tablets, we will have to resort to injections. And sometimes when it is a pressing emergency and we really don't have much time for the patient to improve the hemoglobin levels, we might have to resort to blood transfusion. So this is a broad spectrum how we treat anemia. Now, coming to the fetal effects. So before I go to the treatment, I would just want to highlight upon what are the important, what kind of effects a low blood volume can have on the baby, the growing baby. Because when we talk about pregnancy, we have to give equal importance to both the mother as well as the baby in the womb. So the baby can, usually the baby escapes if it is a mild anemia, because baby just extracts what it wants. So it is generally the mother who is more at a disadvantage. But let's say if the anemia is moderate or going beyond that, then of course the baby also gets affected. And how does the baby get affected? It can lead to intrauterine growth restriction. So these babies can have low birth weight, so they may not be having the expected birth weight. If some baby is supposed to have around 2.75 to 3.2 average size baby at term, the baby might have a low birth weight, something like 2.5 or less than that. So any baby less than 2.5 kg is a low birth weight baby. So somebody who doesn't get enough nutrition in the pregnancy, have severe anemia, or they have protein deficiency, can have a low birth weight baby. The other effects can be a preterm labor. So what exactly is a preterm labor? Preterm labor is when the baby is not yet fully mature, but the mother goes into labor. And why does this happen? Why should preterm labor happen in anemia? There is no clear-cut answer for that, but it can be possible that somebody who is nutritionally deficient can be deficient in other aspects as well. And so they do not have the strength to carry the pregnancy till the end, till the term. So it's possible that they might end up in a preterm labor, which is labor happening before 37 completed weeks of pregnancy. And earlier the labor, the more the problem, because the baby is not fully mature. It cannot survive in the outside world, especially the lungs mature around the 34 to 36 weeks of gestation. So ideally, if somebody goes into labor before 34 weeks, the lungs are definitely not mature enough for the baby to survive outside. So it will need some amount of support. Sometimes it can be oxygen support, or the more the prematurity, it might even need ventilation. A baby which delivers around 28 weeks might even require ventilation. So the prematurity issues are complex and they range depending upon the gestational age. So the earlier a person goes into preterm labor, the more the problems. The other reason what anemia can lead to is lot of infections. Basically, people with anemia have low immunity levels. So because of low immunity levels, again, they are prone to recurrent infections. The infections can be anything like a urinary tract infection, which is repeated, or it can be something like a vaginal infection, which is repeated, or it can be an infection of the placenta and the membranes, which we technically call it as chorioamnionitis. So they are more prone to acquire any of the infections because of the low immunity levels. So once there is some amount of infection in the body, which is subclinical, again, that is a trigger factor to have a premature or preterm labor. So these are the issues which can happen in pregnancy. Apart from that, so I have discussed intrauterine growth restriction, that is low birth weight, and preterm labor, subclinical and clinical infections because of low immunity. And because of this, baby also might have low immunity levels when the baby is born. So these are some of the more serious effects on the baby. Usually a mild anemia which is recognized immediately and corrected immediately, the baby may not have any of these issues. So therein lies the early detection and early treatment value. So that's about the baby part. Now coming to the treatment, how do we treat anemia? So like I said, treatment is both nutritional and therapeutic with medicines. Coming to the nutrition, there is iron which is in the diet. So iron is present in both vegetarian sources as well as non-vegetarian sources. And when in the vegetarian sources, the commonest sources are something like green leafy vegetables, dates, almonds, pomegranate, cabbage, spinach, drumstick. Drumstick leaves are supposed to have rich iron. But the problem with vegetarian sources of iron is most of the iron is not absorbable. So they say the non-vegetarian sources of iron are better absorbed. The vegetarian iron has lot of phytates. So these are plant products. These are complex plant products which inhibit the absorption of iron. So the non-vegetarian has a better absorption. But for people who are pure vegetarians, we might have to supplement them with iron tablets. So the non-vegetarian sources will range from meat, eggs, liver. Liver is a very rich source of iron, heme iron especially, and the absorption rates are also higher. Fish. So the common non-vegetarian sources contain iron, which if taken in adequate and in moderation can prevent anemia. So that's about the diet part of it. Then coming to the therapeutic, that is the medicines. The most common medicines which any pregnant woman takes are iron tablets. Generally, iron and calcium are recommended throughout the pregnancy. So anybody who has been through a pregnancy, they are very familiar with iron tablets and calcium tablets. So iron tablets, the market has a lot of preparations. So most of the preparations range from something which is less irritant to the gastric system, because iron per se is a irritant of the stomach. It irritates the stomach lining and it can cause a lot of gastritis. Somebody who has a reflex, who's already having problems with the stomach and bowel, these problems get worsened when they take iron. So that is why we find a lot of pregnant women, although we tell them to take iron tablets, the compliance rates are very less. More so in the rural areas because they do not know the importance of taking iron tablets. So even if the government is distributing them free of cost, they do not understand the importance of it, and the compliance is very less. And that is why we tend to see such a high incidence of iron deficiency anemia overall in the country. So coming to the iron preparations, we have a lot of tablets in the market. So there are certain preparations which do not irritate the stomach so much. So the newer preparations like pyrophosphate, iron pyrophosphate, etc., can be taken. The standard preparations like ferrous sulfate and ferrous ascorbate, they are very good. They have a good bioavailability. They're absorbed very well, but the only downside is they can irritate the stomach. The other thing is it can also cause some black discoloration of the stool. So a lot of people, the moment they take iron tablets and their stools start getting black discoloration, they start worrying, okay, something is going wrong with us. So that's not the thing. So generally, if somebody is put on iron, we need to give them instructions. Like, of course, this is to be expected. You might experience a little bit of aggravation of nausea, vomiting, a little bit of discoloration in the stools, and uh, um, other important information you need to tell them when they're taking iron tablet is not to take iron and calcium together, because both are heavy metals. When taken together, neither iron is going to get absorbed well nor calcium. So it's better to space them and take. The other important thing is to take iron with any vitamin C. So vitamin C is acidic and it increases the absorption of iron. So if somebody can take it with a vitamin C tablet, well and good. If not, at least with a small glass of lemon juice can increase the iron absorption. Another important thing you need to tell them is not to take iron tablets with coffee or tea, because these contain tannic acid. Coffee and tea contain tannates. So tannates, phytates, these complex substances, they again inhibit iron absorption. So somebody thinks that they are taking iron, but if they are going to combine with any of these, the absorption is not going to be good, and their hemoglobin levels are not going to rise as much as we expect, or they won't reach the optimum levels. So this important dietary advice is a must when somebody is taking iron tablets. So that's about the oral preparations. The recommended dose, what we give is, there is a prophylactic dose. This is for people who have just 11 or borderline hemoglobin. So they just need to take a single tablet. But for people who are already having established anemia, let's say their hemoglobin is 10.5 or it's falling less than 10, then they need to take it twice or thrice a day, depending upon the severity of the anemia. But of course, when somebody takes 2-3 tablets in a day, the effects on the stomach and on the bowels is going to be a lot. So it depends whether they are able to tolerate it or not. So once they are not able to tolerate oral iron, then we resort to the parenteral iron. So parenteral iron is nothing but taking iron injections. It can be either intravenous injection, where it is directly put into the bloodstream, or it can be given intramuscular, where it is injected into the muscle. But nowadays, we are not commonly following the IM route. The more preferable one is the IV, where but iron injections have to be given under strict monitoring and supervision, because sometimes iron can cause a lot of reactions in some people. So it is advised to take iron injections only in a medical facility under strict supervision. It should not be tried at home. It cannot be given by a common man. So coming to the various iron preparations, we have the common IV preparations, iron sucrose injections. So iron sucrose injections, 200 milligrams can be taken on every alternate days. Basically, before giving iron injections, we see what is the hemoglobin level of the patient and how much of a requirement they have. So we need to do a calculation there. It's a simple calculation. What is the deficiency? How much target hemoglobin we need to raise? Like, let's say somebody's hemoglobin is around 9 or 9.5, and we want to raise it to 11.5 or 12. So we calculate the deficiency, and accordingly how much milligram of iron has to be given, and that is given in divided doses on alternate days if it is a iron sucrose injection. Now we have newer preparations like the iron carboxymaltose. It's called an FCM injection. So FCM injection up to 500 milligrams can be taken in one day. So these are given mixed with normal saline as a slow IV infusion under strict monitoring. Before and after giving an iron infusion, we need to monitor the vitals of the patient, whether somebody's pulse is all right, somebody's blood pressure is fine, do they have any pre-existing fever. All these things need to be checked before an iron injection is given, and after the iron injection is given also, because let's say somebody developed reaction or low BP, they have reacted to the drug, and we do not check the blood pressure or the pulse at least, and we send the patient off, it's possible that they will go and faint. So monitoring the vitals before and after transfusion is giving iron injection is very important. So that's about the iron injections. Now, when somebody's target hemoglobin doesn't improve either with oral or iron injections, or we have very less time, somebody is going to deliver within a week, and we find that their hemoglobin is very less, like 6.5 or 7. So we really don't have so much time. The rate at which the iron levels increases, we need to increase the iron levels minimum zero point 0.8 grams in a week or 10 days. So if you don't have that much time to increase 4 or 5 units in a matter of 5-6 days cannot be attained. So for that reason, we have to resort to blood transfusion. So blood transfusion is given for very, very specific indications when somebody has very severe anemia and there's no time to correct, or somebody has anemia and its complications like heart failure. So somebody has already developed swelling of feet and their heart is failing, then we have to give blood transfusion. Or somebody is actively bleeding, like sometimes some catastrophic complications occur in pregnancy around the 8th or 9th months. There can be sudden bleeding. Somebody can have a low lying placenta and they may present with heavy bout of bleeding. They might have normal hemoglobin levels to start with, but because of the complication, they might have a lot of blood loss, and because of that, they might end up in anemia. In those circumstances, we have no choice but to resort to blood transfusion. So, when giving blood transfusion, we need to be careful to make sure that the blood is screened, it is free of HIV and other viruses, and the blood group is matched preferably. So Rh negative person should not get Rh positive blood. We should not end up leading to any blood transfusion reaction. So basically, there is multiple checkpoints. They check at the blood bank, then again before giving to the patient. So all these checkpoints have to be seen, and then cross-matched blood has to be given. So that's to treat severe anemia, or somebody is having an active blood loss. That's how we treat. So that's about the treatment of anemia. So now I think I have loaded you with a lot of information. So basically, the importance of this topic is anemia is such a common problem in pregnancy. Not that everybody will be requiring an iron injection or blood transfusion, but it's most commonly a lot of people will be needing dietary advice for anemia, and also the tablets, like how to take, when to take, whether to combine with this or not, how many doses to take. So this information is much, much more important when we talk about anemia and pregnancy. So yeah, with this, I'm winding my topic. Thank you so much for giving me this opportunity, and I'm open to any questions. Okay. I believe there are no questions in this session. So thank you once again for giving me this opportunity, and hope you all hope this was an informative one. Thank you.